I use clinical data all the time in my work. I've used large data sets of clinical data. The first one was looking at patient transfers in the hospital. So for example, when I was a nursing unit manager, I noticed that patients were increasingly being transferred within the hospital. So my ward was a respiratory ward, but I might receive a patient with another diagnosis, so an outlier patient. And I thought this was happening more and more often. I also thought that this had implications for patient infection. We all know that infection can be transferred from one person to another, and that healthcare professionals are often implicated in this. However, I thought to myself, well, yes, but the patients are moving around too. Are they transferring infection? I use administrative data and clinical data. Administrative data is data that's also collected by the hospital and health services, and that shows you the incidence, the number of patients that are in, where they are, which is what I needed. And usually this information is collected by the finance department. So it isn't quite clinical, but you need it. The clinical data that I used was looking at diagnosis-related groups and patient outcomes. In the hospital setting, you have many collections of data, but they're what we call disparate, so they're on different systems, and many of the systems don't talk to each other. What happens though is that this data is usually transmitted to the health department. And up in the health department, they have a system which is a data warehouse called HIE, Health Information Exchange. HIE then welds all this data together so that each individual patient has then a record. So I obtained the information from HIE, it was downloaded from HIE from the department, and I was able to then look at an individual's movements within the hospital setting. Now, because the administrative data was mainly finance, the codes behind that were mainly financial. So you do have to do some manipulation to get what you want. So for example, a finance code was for discharge, and that's all well and good, but if a patient had been transferred to a ward and then was discharged from that ward, the transfer was not recorded because it didn't mean anything. If a patient was transferred from a high-level, high-cost area, such as intensive care, to a ward, that would be recorded because of the implications for finance. So because of this, I had to write some syntax to determine every movement that the patient made. I should say that at that time, the electronic medical record was only being rolled out, and so some wards were on it and some wards weren't. So to get around this, I therefore had to use entirely the manual system because we didn't want data discrepancies. I then looked at the diagnosis-related groups to find out if patients who were moved had a greater risk of infection. Yes, they do. So we found that from this data, that hospitals, or that hospital, was transferring 3,000 patients a month within the hospital, which is phenomenal. The increased risk for patients was that they were more likely, by 25%, to get an infection. They were also more likely, if they were elderly, to fall. So this has implications for clinicians. Should we be transferring the elderly? Should we be transferring anybody unless we really have to? Because if they do end up with a complication, they're going to stay in hospital longer, they're going to suffer from that effect. We need to reduce our complications. So that's one example. Another example of what I'm working on at the moment is that I've taken patient data from a Southwestern Sydney hospital, so the entire inpatient database, and we're looking at whether those patients have received an interpreter. First of all, we've examined the patient records to see if they were identified as needing an interpreter. When patients come into emergency, there's a section on the front form that says, do they need an interpreter? So we found that a large percentage were recognised as needing an interpreter. When you actually go down further to examine if they received an interpreter, unfortunately it's only 18%. So there's a big discrepancy from those that have decided they need one and to those that they get one. However, bear in mind that sometimes patients might think they need one and they don't, or the record might be old, and so maybe their language skills have improved since the time that that box was ticked.